I do with the last lecture? No, I said, I mean, I can come and you can give me your questions, but I didn't plan, I don't have any lecture called Review Neurology. I mean, it's up to you. If you want me to come because you have some things you want to, I can make it an office hour, but I don't think we'll have a formal lecture, and you can schedule. Yes,
Can we do nephro earlier?
Yeah, can you move up acid base?
Move up nephro?
Because that's from 2 to 5.
Because nephro's at 2, and then this one's scheduled at 12, at 11:30.
So you've looked in the lecture, in the schedule, right? We don't have any more neurology lecture. That's correct, right? Okay, so if that is the case, I can just scrap that review, bring neurology up and extend it, because you're going to have EKG today. So so I can bring up neurology, nephrology, and we do the acid base and do the review. I have like 4 hours to do all of that, so that you're really solid on that. Will that work?
Yes.
So everybody agree you don't need to do a review on neurology. If you do, text me or something. We'll work something out. Okay? All right. So let's talk about neuropathy. This is a very boring topic because neuropathy just means neuron disease, right? It's nerve damage and injury. And most of the time when we talk about neuropathy, we're talking about either demyelination or axonal degeneration. Basically, the point of this slide is to let you know that neuropathy simply means nerve damage and injury. And it's a laundry list if you want to look at the causes of it. See, when you see any disease that has this kind of long list, invariably we don't treat these diseases, the causes of them. We treat them systematically. Right? All right. So, is that my voice? Right. So you see, look at the causes of nerve injury: systemic diseases, diabetic neuropathy, renal insufficiency, hypothyroidism, chronic liver disease, celiac disease, any critical illness, vasculitis, systemic lupus, scleroderma, rheumatoid arthritis, polyarthritis, granulomatous, Church-Strauss, CREST, cryoglobulinemia. You know, if I was to do a review, we're not going to do one, but if I was to do one, I would take a slide like this. You know why I like this kind of slide? And I would paint a clinical picture of each of these. Right? Not only does it allow you to kind of like review nerve injuries, but you also have an opportunity there to talk about Church-Strauss, talk about polyarthritis nodosa. So you can have the broad review, which is the kind of things we'll do when we do internal medicine 3 when you come back from your clinical rotation. That internal medicine 3, I'm revamping that entire series to make it look more like a PBL that is truly straight to the point. Yeah. Okay. So you see, it's a long list, right? Infiltrative disorders like sarcoid, amyloidosis, infections, HIV, Lyme, leprosy. Look at nutrition deficiencies like vitamin B12, B1, vitamin E, vitamin B6. The ones that we know for sure is B12 and B1. Then immune-mediated Guillain-Barré, chronic inflammatory demyelinating polyneuropathy, multifocal motor neuropathy, sulfatide antibodies, monoclonal myelin-associated glycoproteins. You see, it's a long list, right? Basically, neuropathy, what do we care about it? If you have it, you give the patient Neurontin. That's it, right? And then if you can identify any underlying cause, you deal with it. And sometimes part of your underlying cause might be a medication that you have given or somebody has given the patient. Many chemotherapeutic agents damage nerve cells. Many antimicrobials like chloroquine. You know what chloroquine is used for? Good. Yes. But it's old now, right? Nobody uses chloroquine anymore. A lot of allergies, sir. Colistin, Dapsone. What is Dapsone used for? Dapsone. Huh? What is it used for? Leprosy, right? Itraconazole, lamivudine, you know all the rest of that one, right? and then look at environmental. This slide is the most comprehensive list of environmental causes of nerve injury. But whoever made it, they don't even know how to spell household. Right? So, so I know what I'm going to do. I'm going to cut it at the top and put in a text box and spell it correctly. But it's a good list of household and environmental. Do you understand what the point I'm trying to make here with the last 3 slides? Neuropathy is a nuisance. It's not a disease. Basically, because if it's a disease, you'll be able to treat it and relieve your patient. Neuropathy, you will not be able to treat most of the time. You will bother your patient will bother you, and there is nothing both of you can do. Because even neurontin doesn't work all the time. I mean, those are the kind of patients you see on your schedule, and you're like, oh, Lord have mercy. And you pray before you go in because you have nothing to offer them. And then you leave the room, you were like, why am I even getting paid for seeing this patient? Nobody is getting help here, right? And then I give them 6 months follow-up. Why you give me so long? Appointment, you want to come sooner? If you want to come sooner, I'll see you in 3 months. That's how you test your patient if they're tired of coming to see you, because you're not really helping them. Okay. Now, but in terms of pathophysiology, what are the types of nerve injury? Beautiful thing is, there are usually 2 types, right? They are demyelinating injuries or axonal degeneration. So you see, when you have demyelinating, the nerve loses its myelin sheath, right? And when the demyelination has been going on for a long time, the nerve cells replaces the myelin sheath with sodium channels to facilitate conduction. Because remember, the purpose of myelin was to facilitate conduction, right? And then the second type is the axonal degeneration, when the axons actually degenerates. Okay? So those are the 2 types of injuries. And many, many times when you send people to neurology and they do nerve conduction studies, the point is to differentiate demyelination from axonal degeneration. I am not a fan of it because it does not matter whether the patient has demyelination or axonal degeneration. It does not really. It does not inform your treatment in any way. What is the point of knowing whether it's axonal or demyelinating? It's just good to know for academic purposes that this could be either, or your patient could ask you, so why do I have this? Even though we don't have a treatment, why do I have it? Yes, well, nerves have a covering like cables that protect them. You're losing the covering of your cable, or your cable is getting shorter. So you can use that to explain to them. But other than that, what is the point of classifying these things into these 2? But people they take time to differentiate between demyelination, axonal neuropathy in terms of clinical evaluation. And if you take a good look at this list, you can actually assume it's not particularly specific, because see, for instance, in axonal neuropathy, it is usually gradual or insidious in onset, whereas in demyelination, it is either acute or subacute. For instance, something like Guillain-Barré is very acute, right? Axonal neuropathies tend to affect large and long nerve axons early, whereas demyelination tends to be diffuse and starts in the lower limb, but it's always distal, right? But let me ask you something. Truthfully, is there a difference between these 2? Look at it. Large and long nerve axons are affected early. Hence, initial lower extremities are affected. Starts in lower limbs. Is there a difference? Sure. I mean, so sometimes people just, and believe me, when you read different chapters in the different textbooks, that is exactly how it is. At the end of the day, you read a lot, like nothing tells you how to differentiate them, right? When we get to the one that makes sense, I'll let you know. You see this talking glove sensory motor loss with symmetrical distal clinical signs in both arms and legs. That is so true for axonal degeneration. And then it is in contrast with generalized weakness and mild sensory loss that you find with demyelination. Okay? What is true about axonal neuropathy is that distal involvement, whereas in demyelination, it is non-specific. That is important. And that makes sense, right? If the nerves are shortening, right? If the axon is degenerating, that means the nerves are shortening. It will start from the longest nerves, right? So it will begin in the distal part of the body. So that is why this is true. So you see, as a result of distal involvement, ankle jerk is lost early, whereas the proximal tendon are preserved. Whereas in demyelination, there is no such thing. Okay? Muscle wasting. Okay, you can see that muscle wasting. What maintains the blood, the metabolic state of the muscle? What keeps the tone of the muscle? Is the neuronal impulse, right? That is responsible for the baseline tone of the muscle. And that baseline tone determines nutrient flow to that muscle, right? So if you have axonal neuropathy, where the neuron is losing connection with the muscle, you can expect the muscle to now undergo atrophy, right? See, that is why the next thing I will put an asterisk against is this muscle wasting, because it's really it's true, and there is a reason for it. So muscle wasting, distal involvement under axonal neuropathy, and relatively absent in demyelination. The rest of it is so really not non-specific, except that in demyelination, recovery can be rapid because the axon is intact. It is easy to remyelinate than to produce new axon. Okay? So recovery tends to be very rapid in demyelination, tend to be slow with axonal. So in terms of specifics, we should pay attention to 4 or 5 things, actually 4. Gradual, symmetrical involvement, distal, symmetrical, that distal and ankle jerk being lost first, they're one and same thing. Muscle wasting, extremely important. Those 4 facts are very important for you to differentiate between axonal degeneration and demyelination. Okay, so in terms of, those are the types of neuropathies. We also classify neuropathies based on the pattern of nerve involvement, right? So I want to make sure you're following me here. Neuropathy you can classify in terms of the pathophysiology, either as demyelination or axonal degeneration. That is one way. That classification is based on the pathophysiology. Based on the way your patient presents to you, you can also classify neuropathy. You can classify them as mononeuropathy, when the clinical feature is so specific for a single nerve, right? Or it could be multiple mononeuropathies, that is single nerves involvement at the same time. Or it could be polyneuropathy. Polyneuropathy means symmetrical involvement of many nerves, right? So understand that mononeuropathy just means single nerve involvement. Multiple mononeuropathies means multiple single nerves involvement in an asymmetric fashion. Okay? Polyneuropathy is generalized multiple single nerves involvement, but in a symmetrical fashion. Okay, so symmetry is important in terms of differentiating polyneuropathy from multiple mononeuropathy. Okay, and there is all kind of other classifications that we use to define neuropathies. They may be categorized based on whether it's a motor neuropathy or sensory neuropathy or autonomic neuropathy, right? Remember, we talk about autonomic neuropathy when somebody has positive orthostasis. If they have diabetes and they have positive orthostatics, you say, oh, this is autonomic neuropathy, right? If it could be sensory, they could be acute, meaning the neuropathy comes on in hours or days. It could be subacute, talking about weeks or months. And it could be chronic, when you're talking about months or years, okay? But pay attention to that last bullet. The most common form of neuropathy is symmetrical peripheral polyneuropathy, which mainly affect the feet, leg, on both sides of the body. And that is the one you see in diabetics, okay? So this is a table of mononeuropathies, okay? In the upper extremities, the nerves that are most vulnerable are radial, median, and ulnar. I think somebody should have talked to you about this. You talk about claw hands and benediction. You did about that, right?
Yeah.
Orthopedic, right? Excellent. Okay, I'm glad they did. Yeah, because I didn't think this is where you should learn this. But this is a table, a very good table, I have to say, that tells you about the nerve. These are the major nerves in the upper extremities. Radial nerve, responsible primarily for wrist. So when we're testing for radial nerve in the clinic, you're looking at wrist extensors, right? So that's how you examine it. Sensory loss is usually on the radial aspect. Median, you talk about muscle wasting and precision and pinch function, because that is usually your thumb and stuff like that. And then the ulnar nerve is mostly this one. You know when you hit your funny bone? Pyong, like that, right? Okay. So look, what does it matter? If somebody comes with carpal tunnel syndrome, or say median nerve problem, and you misdiagnosed it as a radial nerve problem, what will happen? Will they die? I mean, at the end of the day, what will happen? You give them a wrist brace, right? And tell them it will go away, right? So this is for you to know for exam purposes, okay? And there is something called, did you guys talk about Saturday night palsy? You didn't? You did. Right. The one you get in the guys when he gets drunk and he puts his hand over the couch or the table or the chair and compresses the axillary nerve and then he wakes up with paralysis. And it's called Saturday night palsy. Okay. So these are the nerves that are vulnerable in the upper extremities. When they are compressed in neuropathies, this is what they look like. Median nerve compression is called carpal tunnel syndrome. What are the factors, risk factors for it? Tenosynovitis, arthritis, strenuous exercise, and sometimes repetitive elbow motions, like those cash registers and those people that park in grocery stores, currently always moving their wrist like that, you know. And that's what I always tell my patients, and you should tell your patients, the time to go to school is when you're young. It is not when you waste your life and then in your 50s you're going to be a security guard. I mean, security guard is not what you should be doing at 50. Security guard is what you do in your 20s and 30s while you're in school. Because the truth is your body grows weaker. So as your body grows weaker, you want to develop your mind. So you can make a living with your brain, not your body. When you waste your life, you don't develop your brain, then at 60 you go to start doing security jobs. Right? I mean, some people don't have a choice, right? They come in here, they come from all over, and they go to CNA school. In 6 months, they get a license, and they now go and be packing poop and cleaning all these home health people. Well, I tell them you can do that for maybe another 6, 7 months, maximum 2 years, and leave before you get hurt. You know how many patients I've seen come in here and take up those odd jobs and 3 years later, they have serious back pain, and sometimes they get paralyzed from nerve compression, spinal cord compression, from jobs they took, right? So people don't understand that there is a way you're supposed to live. When you're young, you're strong. Do the hard labor at that time while you're developing your mind. Because when you're young, you're also dumb. So you're strong, right? So use your physical strength to make a living while you educate your mind. So that as your body grows weak, your mind is stronger. So when I came here, I was a patient escort at UCLA. I used to push those hospital beds with pumps and devices. I was strong. I'll push them, barrel them down the hallway. People will look at me, whoa. Because I have everything hanging and I'm moving it sometimes at high speed. Can I do that now? No, I can't. Because I even got hurt from that stuff. That's where I got my back injury from. If I hadn't gone to school or tried to pass my exam, how long do you think I would have been able to do that? By now I'll be on disability. And because people don't realize it all the time, they always think they're going to stay young forever. And they have all these pharmaceutical companies deceiving them, right? Take this, youthful whatever, youthful that. You will never wrinkle with this. Hello? Look at Michael Jackson, man. You know, it doesn't matter how you fix it, you're going to age. That's the curse. Okay, we can struggle and try to escape it, but the truth is that's our reality. So all these neuropathies, they are usually work related. You know, the ulnar is in the elbow cubital, right? And tennis, of course. Remember, you guys talk about tennis elbow, right? Okay. And then the radial nerve, that radial nerve compression in the axilla that I told you gives you Saturday night palsy can also happen when you are on crutches for a long time, because you can also compress the same nerve in the axilla, right? So this is a very good summary table for you, but my intention is not to go into all these specifics. My goal here is to let you know what are the upper extremity mononeuropathies and what are their risk factors and how they present. So radial nerve, remember, radial nerve will give you drop wrist, right? Medial nerve can give you ape hand or the bishop's hand, right? You know the Pope when it comes. Right? So remember that. That bishop's hand and ape's hand, and then the claw hand for ulnar. So these pictures I have here, they are related to the nerve in front of them. Drop wrist is for radial nerve. Ape hand and bishop's benediction is median nerve, right? And ulnar nerve is this claw hand right here, okay? And I hope you know that median nerve affects, you remember what the lumbricals are? You remember lumbricals? Okay. Well, you did anatomy. That's why you did anatomy, right? Okay. Now, of all these mononeuropathies, which one are you likely to see really in practice? No, I know you will see it. It's carpal tunnel syndrome. Okay. Remember that fascia that binds everything down at the wrist, because all the nerves and the vessels, they're traveling freely from the forearm into the hand. They are bound at the wrist to keep them together by that fascia. And so when you have inflammation, arthritis, ganglion, anything that makes that fascia tight will compress the median nerve, right? And that really is the basic pathophysiology of carpal tunnel syndrome. And you heard about all these Valentino and fixed signs, right? Okay. All these are just for academic purposes. Carpal tunnel is no different from really ulnar or radial injuries. You do the same thing. You splint it and you rest the joint. There is nothing. I mean, people just wanted to make a name and get a paper, and they describe all these signs. And people go and test them in exams. But clinically speaking, does it matter? No, it doesn't. It really does not, because what do you do for carpal tunnel? You put splint and decompression surgery, like the fascia release surgery, it doesn't work 50% of the time. Why would it work? Think about it. If you slit the fascia open, it will heal. What happened to scars over time? They contract, right? So you're just like, and the unfortunate thing is that once you do it once, you can't go back and do it again. So if you do it for somebody, do fascia release surgery for carpal tunnel syndrome now, 50% of the time they will not get any benefit, right? 50% of the time they will get some relief from the burning and the weakness. Give them 5 years. That fascia is going to heal and it's going to contract, and they will repeat the same thing. And now you can't go back in there. Because when you cut through a scar tissue, it doesn't heal as fast, as quickly as when you first inflicted it. The only time I push for fascial release is when the patient is actually becoming weak. They're dropping things because they're losing strength in the hand. I can do the surgery to help them gain strength so they don't lose their job while they retrain for other jobs. Okay? And guess who I see carpal tunnel syndrome in the most? They're usually 60-year-old people, mostly immigrant, but sometimes Americans who never graduated high school, and they couldn't even tell you what they did, right? But now in their 60s, they've been denied Social Security, and they have to go look for something to do. Now they go work in grocery store. I'm like, what a flipping bugger! What you're supposed to do as a teenager? It's not meant for you in your 60s. And then 2-3 years into the job, they now are truly disabled now. And this is the story of the population you're going to deal with. Because they were denied when they didn't have a disability. And you know, the state has a doctor that they send the patients to, right? So they go apply for disability, the state denies them. It goes in their record that they've applied and they have no medical reason for disability. That now forces them to go get a job wherever they can find it, right? Housekeeping, cleaning, whatever it is. But they get this job. And they get it in their late 50s, early 60s. They do it for 2-3 years and they suffer the consequence. Now they have a real disability. When you now complete the disability paperwork for them, the doctor does not look at the patient, he looks at the record. Oh, you've been here before 3 years, you still won't qualify, denied. That is when you now have to pick up the phone and advocate and let him know that, did you look at the patient? I know the records say that she was denied 5 years ago, but did you take a look at her? And sometimes you have to be really tough. I've had to tell people on the phone that, listen, if you don't agree at least to do due diligence and take a second look at that patient, I will move her to sue that agency and I will take the witness stand against you. And then let us not go that far. Let us not go that far. Right? You know, but sometimes that is what it takes. You know, otherwise people are mean. When they think they can get away with stuff, the heart of man is really wicked. And you really have to know when you can speak up and not get hurt. And just do it. Right? So, again, ape hand, median claw hand, deformity with impaired opposition. Okay? Now, let's talk about lower extremities mononeuropathies. In the lower extremities, the 3 nerves, in the upper extremity, what are the 3 nerves you're worried about?
Radial, medial.
Good. In the lower extremity, you're worried about sciatic, tibial, and common peroneal, right? Sciatic nerve, oh my goodness, is the longest nerve in the body, right? And you know all these people that go to all these places and say they are CNAs and LVNs, sometimes they are not well trained. When you want to give, were you trained out to give IM injections in the butt? Right? You divide the half butt into 4-quadrant, right? And you put your injection in the upper outer. Some people are not well trained. They divide the whole butt into 4-quadrant, right? And put the needle right there, and they hit the sciatic nerve a lot of times, especially in developing countries, like Bangladesh and
Nigeria.
Guatemala, Nigeria. Nigeria, not in the cities most of the time.
Happened too.
Yeah, some of these people in the villages, they say, when some people just work in a hospital, but in the village, they're doctors. They might be cleaners, housekeeping people in the hospital. But when they go to the village on vacation, they carry medication, and the doctors, everybody goes to. He works in the hospital, and people get hurt. So these things, the one that you will anyway. So how does it present? Sciatic nerve, you have pain. Down the back of the thigh and stuff like that. This, as you can see, this I lackluster, right?
Yeah.
Yeah, the topics makes me like that. I hope it's not affecting your learning, right?
No.
Okay. And then fibular, the peroneal nerve. How do you get it? Ladies, and they cross their legs like that. That is a common risk factor for that. Foot drop. And then tibial. What should I say? What is, if I was to present this slide in 2 sentences, I'll tell you the lower extremity mononeuropathies affect sciatic, peroneal, and the tibial nerves, right? Invariably, they give you pain and numbness, right? And when it is severe, you get a foot drop. Now, when do you want to make sure you diagnose foot drop? Because I had a patient of mine that had foot drop, and I did not know it because she had been with me for so long. She has some, oh my goodness, she has the worst case of spinal arthritis I've ever seen. And she's been with me for over 15 years. And I knew the arthritis was getting worse. I hesitated sending her to surgery because it was multiple level involvement of the vertebral column. And I knew surgery was useless because the kind of surgery she needed, nobody would do it, right? But after a while, somebody convinced her that she should put pressure on me to send her to surgery. I said, fine, no problem, I'll send you to surgery. She'll send her to surgery. And the surgeon told her exactly what I had told her, that when you have inflammation or degeneration in the spinal column, if it's a huge small level, 1 level, 2 level, we can replace those with titanium plates and take them out and put plates on either side of it. We can do that. But once you have multiple levels that goes from your cervical down to your sacrum, we don't have a way of replacing vertebrae like that. There's no point. Let's do physical therapy. I sent her to physical therapy, and then somehow, after she went to physical therapy, I think the chiropractor did not know how bad she was in the spine and put some pressure in some places, and she developed foot drop. And I did not know about it because she's been with me so long that the thing was becoming monotonous, right? So many times we just sit and talk. And then I would always listen to her heart so I could write in my note that chest is clear. I didn't do a thorough physical examination until one day she tripped and fell. So the doctor called me. I said, bring her in the next day. So brought her in and I examined the gate, and there it was. The wrist, the foot had been dropping and it got caught on the rug, and that's how she fell. Okay. So what did we do? We put brace, but then she hated the brace, and she stopped wearing the brace after like 2 months because When I gave her the brace, I told her this is not going to make the foot drop go away. It will prevent the fall. But she didn't want to go through the trouble of having to put on the brace every single time she's going out, because it takes about 5 to 10 minutes to put on the brace. You have to like put all these hooks and latchets and stuff like that, you know. But now she's gotten used to actually lifting her feet so high so that the foot doesn't get caught in stuff again. Why am I telling you this story? This is a simple problem, but it doesn't go away. But if you miss it, it can predispose the patient to more serious problems. It turns out that she was a young woman, right? Late 50s, early 60s. If she was like in the 70s, that fall right there, all she needs is to hit her head, and that would have been the end of it, you know. So that is why I just want us to kind of pay attention to this thing here. Again, differential diagnosis of foot drop. It could be sciatic or peroneal, right? It's everything I've been talking about. How do you manage it? Pay attention to the predisposing factor. Once you see it, look for the specific signs. X-ray and MRI, nerve conduction studies, EMGs. Yeah, if you send them to neurology, they will get all those tests done. It's not because they will help the patient, but because the neurologist can bill medical for it. The patient is not going to benefit anything. Okay? How do you manage it? If there is pain, you can give NSAIDs. Steroid injection, yes, sometimes. Physical therapy, range of motion, ultrasound, there is the TENS unit, there are splints, surgeries, indicated for refractory patients with positive nerve conduction studies. Remember I told you earlier that the only time I will think very seriously of surgery for a mononeuropathy is when the patient is losing muscle strength. So the good thing about nerve conduction study is that you don't have to wait for them to be losing muscle strength. If they have positive nerve conduction study, and the nerve is accessible to surgery, like a split, like the fascial split, fasciotomy for carpal tunnel syndrome, it's always a good idea to at least send the patient on to the surgeon and let them together decide whether or not it's worth it or not worth it. Okay? Any questions on mononeuropathies? I didn't say much. But you get the gist, right? Single nerve involvement, helpless situation, symptomatic treatment and management, splints, and NSAIDs. That's what it is. Let's talk about multiple mononeuropathies. Again, it's a long laundry list. But it's interesting that this long list is different from the previous list, because you notice here that you have a lot of infections and inflammation and chronic metabolic conditions, right? The ones that you really worry about are these cancer related, because cancer is common, and these mononeuritis, multiple mononeuropathies are very common in cancer, both as a manifestation of the cancer and also as a complication of cancer treatment. Okay? As you can see, I'm not going to be asking you a lot of questions on mononeuropathies, right? Now, there is something that you need to know about. It is not a multiple mononeuropathy in and of itself, but it's something that you must think about in anybody with multiple mononeuropathies. It is called complex regional pain syndrome. Okay? CRP. There are two types. There is a type 1 and there is a type 2. The type 1 of complex regional pain syndrome is also known as reflex sympathetic dystrophy. Have you heard that before? Have you heard it before? No? Oh, okay, then we need to talk about this. All right. And then the second type of it is just called causalgia. This condition is not understood. We don't know what causes it. But what we know is that patient suffers an original injury. It could be a fracture, it could be any acute injury. And somehow that injury results in some activation of the sympathetic nervous system and the pain fibers in that extremities. Okay? And the sympathetic nervous system will trigger pain and blood vessel changes that will cause swelling. So the patients will present like usually about 4 or 6 weeks after, say, a fracture. They'll present with pain, swelling, and the skin will be shiny, sometimes sweaty. It looks exactly like cellulitis, but it's not warm. Right? So it's not an inflammation. And what is bad about it is that it's very, very difficult to treat. Very difficult to treat. We've tried steroids, we've tried gabapentin, tricyclic antidepressants, some we use opioids. Sometimes you might need even to combine TCAs with some of these medications together. You can't give steroids for a long time, you know, and ultimately you have to send them for stellate ganglion block. You heard about that before, right? Stellate ganglion block? Right. Okay. Now, how do we prevent complex regional pain syndrome? Early immobilization. So following that initial injury, mobilize the patient early and you can prevent complex regional pain syndrome. Remember, complex regional pain syndrome is not a multiple mononeuropathy. It's a differential diagnosis of multiple mononeuropathy. Okay? Now, this is the big deal. Polyneuropathy. This is the one you will see. Okay? Bilateral symmetric neuropathy. It could be acute, meaning it takes on in days and weeks. It could be chronic, meaning it's been on for months and years. Again, acute inflammatory demyelinating polyneuropathy, that's your Guillain-Barré. It's also known as post-infectious autoimmune demyelinating nerve injury. You can also have tic paralysis, right? Non-infectious tick-borne disease, the Rocky Mountain, the wood tick, and the tick is Dermacentor andersoni, but it could also be the American dog tick, the Dermacentor variabilis, right? And then botulism we talked about, and then toxic neuropathy and acute intermittent porphyria. You all know about porphyria, right?
Yeah.
Okay. So tell me, what are the features of tic, botulism, and Guillain-Barré? You already said that Guillain-Barré ascends, right? You said botulism descends. How about tic? Hmm?
What it looks like from dermatology.
I don't remember what tic does.
Like lesions on their fingers.
No, but I mean in terms of the paralysis, is it descending or ascending? You don't know?
I don't know. What?
Yeah, yeah. I know Guillain-Barré ascends and botulism descends. I don't remember what tic does.
The paralysis ascends to the trunk, arms, and head with an L.
Thank you. It descends too. It's a descending paralysis.
Ascending.
Oh, it's ascending?
Yeah, to the
Okay.
trunk, arms.
Okay. To the tongue.
The
Trunk?
Then the arm that has.
Okay, yeah. So it behaves just like Guillain-Barré. Okay, right. Okay. So it's a differential diagnosis of Guillain-Barré. Okay. And then look at the chronic conditions that will give you chronic neuropathy. It's a long list. It's just a partial listing of what we talked about earlier. Okay. Okay. What are the symptoms of neuropathy? Again, it depends on the nerve groups that are affected. It could be sensory, it could be motor, it could be autonomic. Okay? You know, do you know one condition that is overdiagnosed in this country? Is autonomic neuropathy. Because sometimes people come with dry eye, dry mouth, and you make a diagnosis of what? Sjogren's, right? But many of those patients that have been diagnosed with Sjogren's syndrome are actually having autonomic neuropathies, right? Because autonomic neuropathy presents with lack of tear, lack of saliva, lack of sweat, right? Light intolerance, heat intolerance, gastroparesis. You know what gastroparesis is, right?
Yeah, the stomach is on.
Good. How does it present clinically?
This
Abdominal distension, loud bowel sounds. But what clinches the diagnosis is foul-smelling vomiting. Because they vomit food they ate like 3 days, 4 days. Right? So the food basically decay in the gut. And when they throw it up, it stinks really badly. That's how you know this is gastroparesis. The commonest cause of it is diabetes. Okay? And of course, sexual impotence, bladder and bowel dysfunction for autonomic. Look, for motor, it depends on which group of muscles. So you can have droopy lids, diplopia, dysphonia, dysphagia. All of that are evidence of brainstem dysfunction, right? Right? And then, depending on which group of muscles are affected, in the extremities, you can have problems. Sitting up, standing up, walking, opening jaws, buttoning up, making up, combing hair, brushing teeth, or even turning keys, right? Depending on which group of muscles are affected, it could be motor. And then you have the sensory one, which is burning. What is allodynia?
We have hypersensitivity when.
Good. When somebody gives a pinprick and you feel more pain than you should feel, right? Then paresthesia. Paresthesia can be talked about by the patient in so many ways. The commonest one is tingling, right? Pins and needles. Sometimes your patient will come and tell you that I feel like I'm walking on wool, right? Walking on wool. That is paresthesia, okay? Or I feel like there is a band around my feet, okay? So these are the many ways in which the patients will present with paresthesia. They will tell you all this. So when you hear any of this or you read any of this, that is a picture of paresthesia they are painting for you. They have actual loss of sensation. As a matter of fact, when you have sensory polyneuropathy, you don't become anesthetic. The first thing that happens is paresthesia. The nerve fires. When the nerve does not get a relief, it dies. That is when the patients become anesthetic. That is when they lose sensation. Okay? And then, of course, ataxia, gait imbalance and stumbling in the dark. When you have ataxia that is of sensory origin, it's worse in the dark. You know why? Because during the day, when you have ataxia, you have visual compensation, right? But in the night, you don't have that visual compensation. Your ataxia becomes worse. So the patients will tell you, I stumble a lot in the dark, right? Okay. What are some of the things that you should look for in the history when you're seeing somebody with polyneuropathy that should really tell you, oh, look at it. That should really tell you what you're dealing with. In the presenting complaints, find out, is this paralysis ascending? If it is ascending, you're dealing with Guillain-Barré and tic. Okay? If it is descending, you're dealing with botulism. That's it. Again, if you have an antecedent infection, like if somebody develop an ascending paralysis following camping, you will examine them for tick. If somebody develops an ascending paralysis following an upper respiratory tract infection, you're looking for Guillain-Barré, right? Or say somebody develops an ascending paralysis following a diarrhea, maybe 2 weeks history of diarrhea, and then 3 weeks later they are becoming weak and weak and weak, and you're sure it's not hypokalemia, then you should be thinking about Guillain-Barré, right? Medication, because on surgery and family and social history, occupational exposure and foreign travel, these are things that should clue you in to the etiology of polyneuropathy. When you examine the patient, you want to examine temperature, pain, vibration, and joint position sense. Because remember, when you do temperature and pain sensation, which part of the spinal column are you testing? The anterolateral. When you do vibration and joint position sense, you're testing the dorsal column. Okay, good. Excellent. Very important. So I gave you an example of what can cause distal sensory polyneuropathy and subacute combined degeneration of the spinal cord. That is usually a posterior column degeneration. Okay? So if I give you a picture of a patient with polyneuropathy and I give you evidence of impaired vibration and position sense, and I give you which is most likely, and I give you a list. Is that man sleeping? Man, you got some God, man. Or have you want to stand in the back, man?
I'm feeling dizzy.
Oh, you're dizzy?
Yeah.
Why you? Am I making you dizzy?
No.
You're okay though, right?
Yeah.
Okay. All right. Okay. So, and I give you a list of differential diagnosis, right? And then I give you diabetes, leprosy, vitamin B12 deficiency. You should know. You need to know this. That if I give you impaired vibration and joint position sense, I'm looking for vitamin B12 deficiency. Okay? I ask you first that when you test for pain and temperature, which part of the spinal column are you testing? You said anterolateral. So when you test for joint position and vibration, which part of the spinal column are you testing? You said the dorsal column. Okay? And I gave you an example of a disease that affects the anterolateral column, like diabetes. I gave you an example of a disease that affects the dorsal column, vitamin B12. So I said if I give you a case, I paint a picture for you where I give you paresthesia and I give you specific finding of loss of position and vibration sense. And I say what is the most likely diagnosis? And I give you diabetes, B12 deficiency, leprosy, cancer chemotherapy. You know that if I mention loss of position and vibration sense, you should be looking and thinking more of dorsal column. You should be thinking more of the subacute combined degeneration of the spinal cord, because that really is a dorsal column disease. Okay? I wanted to talk about this a little bit to kind of tell you about what the nerve conduction, this you don't have to worry about, just FYI, what the nerve conduction looks like between demyelination and axonal degeneration. So this is normal nerve conduction, right? This is what it looks like when you have axonal degeneration, and this is what it looks like when you have demyelination, right? So basically, the speed, the latency. So this is normal amplitude, right?
Yeah.
In axonal degeneration, look at the amplitude, it's short. Why is it short? Because it doesn't have, it does not have enough distance to go through. The axon is shorter. So the force needed to propagate it down the axon is not as much as when the axon is the original length. Okay, so you lose amplitude, and in demyelination, you lose speed. That's just basically what that is. In axonal problems, you lose voltage. In demyelinating, you lose conduction velocity. Man. Honestly, I don't know why we're going into so deep a detail. This is basically a figure that talks about how can you evaluate. Please, I hope you know that I don't expect you to memorize this or know anything here. Especially given the fact that I told you that polyneuropathy we treat symptomatically. This is really FYI. You can actually, there are specific conditions that you can have a differential diagnosis of depending on what the nerve conduction study is telling you. Remember, even though we say that neuropathies can be due to axonal degeneration or they can be due to demyelination, that is not exclusive. Sometimes it could be mixed. You can have both of them in the same patient, okay? So this is just a table on what are the differential diagnoses of axonal degeneration, demyelination when it's uniform versus non-uniform, and when it is mixed, right? What I want you to pay attention to though is that, please remember that Guillain-Barré is a demyelinating disease of the non-uniform kind, okay? That is extremely important, all right? Other than that, the rest of this is just, I don't know. I feel like I should delete this slide. You think I should, right? Yeah. Because it's busy, crazy, irrelevant. Yeah. This is, you know this is important, right?
No, you should delete that.
No, seriously. Take a good look. Let's take a good look at this and tell me what you think. I want to be able to see whether you're coming close to thinking like me. Is this an important slide?
Yes.
Yeah.
Yes. Because this tells you see a patient with weakness. You need to be able to tell when weakness is due to brain problem, spinal cord problem, neuromuscular problem, or muscle problem. This is a very important slide, right? Because when somebody comes to you that they are weak, like say for instance, somebody with myasthenia gravis, for instance, they come to you, I can't comb my hair, I can't brush my teeth. Of course, from that history, you know this is most likely neuromuscular problem, right? But supposing the same patient says, in the last 6 weeks, I've been noticing that I get tired earlier when I'm trying to comb my hair, but only when I'm combing with my right hand. If I comb with my left hand, I'm fine. You know that is not myasthenia, right? Because myasthenia gravis is a generalized disorder. It's not a one-sided. But if somebody has a brain tumor that is taking out their motor cortex, it will be one-sided. So if you look at this, you say when you see weakness, you want to decide whether this is due to a brain problem, spinal cord problem, a nerve problem, or a neuromuscular junction problem, right? And for the brain, is it cortical, frontal lobe, or subcortical? In other words, is it within the internal capsule or within the corona radiata? You remember what those are, right? The internal capsule is the condensed motor fibers on their way down. The fanning of them from the motor cortex is what is called the corona radiata. Remember I told you that, right?
Yeah.
Okay, right. And then you want to find out if it is thalamic, if it is brainstem. the question I have for you is, yeah, it could be brainstem, but what would you see in a patient with weakness that is due to brainstem problem?
Respiratory depression.
Respiratory depression is one, but that's a dead sign. If you wait for that, all your patient will be dead before you diagnose them. What else? What is it that they present with earlier?
Cranial nerve deficit.
Exactly, remember that. Multiple cranial nerve deficits is what tells you, because you know what? When you do neurological examination and you say patient is alert and oriented, basically what you're saying is the cortex is intact. When you say cranial nerves are intact, what you're basically saying is the brainstem is fine. Right? So that weakness with multiple cranial deficit tells you, oh, brainstem is involved here. Right? Spinal cord, cervical, thoracic, and lumbar. You can use sensory levels to decide what is going on. Right? If it's cervical, you have quadriplegia. If it is lumbar, you have paraplegia. Right? Okay? And then if it is nerve, see, you talk about motor neuron, radiculopathy, polyradiculopathy, plexopathy. What is plexopathy? The involvement of a plexus, the axillary plexus, sacral plexus, right? You remember that the spinal nerves, they come out singly, but they don't travel alone. They merge and redivide, right? And the initial merging forms what is called a plexus, like the axillary plexus that supplies the upper extremities. It's made up of nerve roots, C5 all the way down to T1, right? And then they merge and then they divide again into ulnar, median, and that involvement of the plexus in neuropathy is what is called plexopathy. And we already talked about all these. And then you remember neuromuscular junction problem, presynaptic and postsynaptic, right? So myasthenia gravis, is it pre or postsynaptic? Okay, what is the example of a presynaptic lesion? Good, all right, okay. Did you find that on the pants? No. They should have asked you that.
I think it was myasthenia gravis was an option.
Okay.
But it wasn't there.
Yeah. All right, and then you have the myopathies, the muscle. So generally speaking, when do you start thinking about muscle disorder in somebody with weakness? Whenever you have somebody with weakness and nerve conduction studies are normal, that is not the end of the road. If somebody has numbness and weakness and nerve conduction studies are normal, that tells you you may have muscle disease, primary muscle disease, or what we call myopathies. And that is when you now do EMGs, electromyographies. Invariably, you're not going to be the one that will do it. You will refer. So you will see somebody with weakness, you send them to neurology, you get a letter back from neurology saying, oh, I examined your patient, nerve conduction studies were normal, consider yada yada yada. They don't give you any specific diagnosis. You don't stop there. You move on to do EMGs. An EMG most of the time will give you some specific information that will help you diagnose the many types of myopathies. But at least you know you're dealing with a myopathy. Why am I not talking about it? Because there is nothing you can do about it. Just say the myopathy is a myopathy. What type does not matter. It does not matter what type it is, whether it's Duchenne or whatever. It doesn't matter. You just send the patient for rehabilitation and help them live with their disability. You can't change anything. Okay? Any other questions?
Oh yeah, you answered my question, but I was wondering, would you see anything in an EEG or an MRI of the brain?
No. For myopathies, no. You will see things in the EMGs and the muscle biopsy. Right, okay? So how do we treat polyneuropathy? Again, like we said, in the acute phase, you resuscitate the patient, immunotherapy. Tick paralysis, you resuscitate, you take out the tick. Botulism, resuscitate, give antitoxin. Toxic neuropathy, resuscitate and detoxify. This is like so redundant, man. This is like a high school presentation. Acute intermittent porphyria, resuscitation and heme therapy. I didn't need to tell you that. You know what to do. If I tell you somebody has tick paralysis, how do you treat it? Even if you didn't know what tick paralysis is, you got a tick. Right? And then for the chronic, you treat the cause. Control diabetes, replace thyroid. monitor liver disease, treat celiac disease with diet, usually renal insufficiency, see if you can replace, vitamin deficiency, replace, chronic alcoholism, send him to AAA, sarcoid, steroids, amyloidosis, wait and watch, Charcot Marie Tooth, say sorry. Right? It's not much that you can do in all of this. Do we have to go through this? This is myasthenia gravis, remember? We went through it a lot, right? Autoimmune neuromuscular junction disorder, present with once in the evening, relieved by rest. Antibodies, differential diagnosis, Lambert-Eaton, Lambert sign, the small cell cancer. You remember all that, right? Do I need to go through this?
No.
Right? We're all on the same page, right? I should skip this.
Yes.
Thank you. And then this is just myasthenia gravis confirmed acetylcholine inhibitors. Remission, you're fine. No remission, steroids. You don't need anything here. Okay? I remember we talked about myasthenia gravis crisis versus cholinergic crisis. Right? One you have to withhold treatment, then you have to be aggressive in treatment. That is important. Don't forget that. It's like Somogi and Down's phenomenon for diabetes. This is in that category. Okay, you can't get them mixed up. Okay? Whew. That was painful. Right. So, in another hour, you're going to do EKG. I have reviewed the questions. I did eliminate 3 strips that were controversial. In other words, they're supposed to be idioparticular readings, but they're not really filling the box. I hope you all had time to review the lectures in EKG, in cardiology. You all did that, right? Yeah, that is important. Because remember, this summer EKG was really review and practice of based off of your EKG cardiology lectures. So if you've read that very well, and you've had practice, which I believe we did, you should be fine with the EKG exam. Do you have any questions? By the way, this last lecture here, what do you think about it?
Sure.
It could have been online, right?
Yeah.
You didn't need to be in class for this one. I'm with you. You know, but at least I hope I communicated to you that you know what neuropathies are and the different types of it, mono and multiple mono and poly, right? And you know that when you can find anything in the nerve conduction studies, you should at least do EMG. There is no reason to kind of like walk the patient up to the detail because it will not matter on how you treat it. Neuropathies are generally treated symptomatically, right? I hope that just drives it home. It's one of those subjects in medicine that we talk about it, but because it doesn't have any relevance for you guys, I didn't think I should bore you with it, but at least you should know about it. Okay? So back to EKG. But you have no question. I'm assuming there's no question about this lecture, right? So any question on EKG, anything anybody wants to, yes?
So
Really?
so say if you have LVH, right? And you know when you have the T typically deflects opposite. Now, I remember you talking about when it's like convex, that's when it's actually an actual arc versus concave.
No, that is not, that is ST segment.
ST elevation.
ST elevation that is really injury pattern is convex. Yeah. When you have LVH and you have ST wave changes, almost always you will call it strain. Right. Yeah.
There was the one example, it was not strain, it was something, it was the, what you just said, pretty much.
Injury?
Yeah.
Any, yeah, Wendy, you had a question?
You know this one?
Yeah.
Why is it A instead of the C? Because I was doing the unless I wrote the answer wrong. Because I was
You see,